Hi, this is Kevin Welcome from the Acme team, and in this podcast I'd like to discuss how to evaluate the validity of your assessment tools. My objective here is that by the end of this podcast you'll be able to describe two frameworks for validation, those described by Messick and by Kane. And for the program that you're currently planning or revising, you'll be able to define your interpretation use argument and then plan to gather data to test the key assumptions of this argument so that you can make a final judgment on whether the intended use argument of your assessment is justified. There are lots of helpful publications describing validity frameworks, but I found this paper really helpful for providing an overview of the different frameworks and how to apply these to programs that I've been involved with. One of the most helpful parts of this paper is that it approaches validity not as a dichotomous outcome, but as a hypothesis to be tested or an argument to be made. And the authors also offer advice on how to strengthen your argument for or against the validity of your assessment tools. How we approach validation of assessment has evolved over the past 40 years, from choosing between different types of validity, such as content, criterion, or construct validity, toward Messick's unified approach, where we compile different sources of validity evidence, including evidence supporting validity of content, response process, internal structure, relationship with other variables, and consequences. Shown here are definitions for these types of validity and analyses that we can perform to provide evidence for or against our validity argument. In Messick's framework, the focus is on the validity argument for or against the tool, on the assumption that the stronger the validity evidence for the tool, then the more valid are the decisions based upon the tool. A more recent framework for making a validity argument is that described by Kane. And rather than gathering sources of validity evidence, this framework examines the assumptions and inferences that we make in our assessment. Incorporated within this approach is the view that any validity argument should consider how the data generated from our assessment will be used. And this approach is particularly helpful in medical education, where we need to make some high-stakes decisions, and we should be able to argue that our assessment data provides a solid foundation for these decisions. So a helpful place to begin is by deciding what you intend to do with the assessment data in the form of an intended use argument, or IUA, which will then direct the evidence that you need to gather to test this argument. So in the podcast on blueprinting, I described how we decided that, based upon expressed needs of learners and the process of blueprinting, our new clinical skill course should provide training on and assessment of knee aspiration on a task trainer. And their intention was to use these observations to decide which trainees are ready to perform supervised knee aspiration on a real patient, which was our intended use argument. So to present our validity argument, we need to gather data to examine each inference that we make on the way to this decision, beginning with inferences on scoring. So details that we might include here are how we developed, piloted, and revised our assessment based upon feedback, whether we had a procedural checklist to capture the essential components of performing knee aspiration, and how we selected and trained our raters. The next inference to test is generalization from a single score to an overall rating of a trainee's performance of knee aspiration on a task trainer. Helpful evidence introduced here is how many assessments were considered in the final score, how we decided upon this number, how many raters were involved, internal consistency of our rating tool, and inter-rater reliability using this tool. Then we move on to consider whether the overall assessment score reflects meaningful performance in real life. We could argue that we made the training context authentic by including a standardized patient from whom students needed to obtain informed consent, and requiring students to transfer the fluid aspirate into the correct containers and order the appropriate investigations. We could also provide data on performance of experts versus novices on our assessment, whether student scores on the task trainer correlate with the rating of performance on real patients, and share the results of factor analysis of our assessment tool. And finally, we can describe how we set the passing threshold for knee aspiration on a task trainer, what impact our pass-fail decisions had on students, and potential beneficial or adverse downstream effects of our decisions, such as rates of promotion or graduation, future clinical performance, and patient safety. In real life medical education, we rarely have all the data to make an unassailable validity argument. So our final task is to make our argument as strongly as we can and then decide to what degree our data support the intended use of our assessment and consider whether we need to revise our intended use given these data. Thanks for viewing this podcast. I hope you found it helpful, and please reach out if you have any questions or suggestions on how to improve the ACME tool.